For the next session, I invite Dr. B.D. Shukla, Dr. Ashish Saxena, and Dr. Marmik Brahmbhatt, who are all leading physicians of the town, as moderators. And we have Dr. Anup Gupta, Dr. Chirayu Vyas, and Dr. Hiren Patel. All of the three guys are interventional electrophysiologists. So that's the interesting session, chair that we have. I would request Dr. Anup to introduce both our speakers first, and then the case scenario, and then hand over the session to the speakers.
Thank you very much, Kamal, for inviting me and giving me this responsibility of chairing this session. So the case is a 54-year-old man with a paroxysmal recurrent atrial fibrillation, past history of COVID positive with a mild COPD, with a normal LV function, mild pulmonary hypertension, no coronary disease. So we are going to discuss rate versus rhythm control. So for rate control, Dr. Annabelle Wogman is going to speak. She's a MD cardiologist in Chicago, Illinois, and affiliated with multiple hospitals, including Rush University and Rush Oak Park Hospital. She is also a professor in Rush University, US, and more than 2,000 Google Scholar citations. So that's quite impressive, and special interest in atrial fibrillation. And for rhythm control, Dr. Rahul Bhardwaj, again from the United States, is going to speak about the rhythm control, particularly AF ablation, PV isolations and all. So Dr. Rahul is working in San Bernardino, California, and obviously did his internal medicine and then cardiovascular training and the electrophysiology training. And again, he has got a special interest in AF ablation. So we will have both the talks simultaneously, one by one, 10 minutes each, and then we will have discussion with Chirayu and Hiren also. So it's over to you, Dr. Annabelle.
Thank you so much for the organizers, especially Dr. Kamal Sharma for inviting me to speak today, and Dr. Purvi Parvani for inviting me to come to this conference. I look forward to debating or discussing this case with Dr. Rahul Bhardwaj, and I heard that he had some music to go along with our rhythm strategy. So, I'm going to have to come up with something as well. Thank you, Dr. Gupta, for presenting that case. Just to summarize, the fact that he's a young man, 54 is young because I'm 10 years older than he is. He's a young man with paroxysmal, and I bold the paroxysmal here because that means that it's not that long of a AFib duration. We'll just define that. He has mild COPD, which can factor into the decision making of what drugs he should be on potentially. He has a past history of COVID-19, which we're going to talk about. But as you mentioned, Dr. Gupta, he has a normal echo. He has a normal coronary angiogram. So there's no doubt that the preferred strategy would be rate control. I mean, this is not that hard. It's so simple that it's as simple as what Michael Jackson said. So this is, okay, Michael, that's enough. So this is the European Society of Cardiology guidelines, 2020 guidelines for atrial fibrillation. A, of course, is to avoid stroke and anticoagulate. This man's CHADS VAS score is 0. And he's 54. So age does not factor in. It doesn't increase his risk of stroke. He's never had any stroke or any other confounding disease that would increase his stroke risk. So he should not be anticoagulated. But the question is, what is better for his symptom control? And that's where rate versus rhythm control factors in. And then C is for detecting and managing his risk factors and concomitant diseases. But the question of rate versus rhythm is always an issue. And we've studied this. I've been involved in many studies looking at whether rate should be the right way or rhythm should be the right way. For this case, it's rate control. So there's no doubt about that. But let me just make sure that everyone is on the same page, because every guideline seems to change the definition of atrial fibrillation just to make sure we're all on the same page. Paroxysmal means atrial fibrillation that terminates spontaneously or with intervention, such as the AV nodal blocks within 7 days of onset. If he had persistent or long-standing persistent, it may be good for him to have rhythm strategy, but we're talking about paroxysmal here. Please stop using lone atrial fibrillation or chronic atrial fibrillation as the ESC guidelines say. But let's just talk about what rate control means. It is the background therapy for all patients with atrial fibrillation. We need to decrease the risk of heart failure with fast atrial fibrillation. And so we need to control that AV node. And we control it with drugs or with ablation. But our goal is now a lenient rate control, because it was found that if we aggressively decrease the rate, that some of them were having dizziness and passing out. So now we have lenient rate control as long as the heart rate is less than 110 beats per minute on a 12 lead, which means that they're resting, they are okay. You can continue that treatment. However, if they're having symptoms, if they're short of breath, or if they're still having palpitations with that control of less than 110 beats per minute, that's when you lower the heart rate a little bit more. And then if they have a pacemaker controlling their ventricular rate, you can lower that rate as well. So only consider rhythm control if the patient is very symptomatic. So these are your options. We have many options in our armamentarium of rate control. We've got metoprolol, atenolol, esmolol. I like nebivolol for women especially. It lowers their blood pressure and they don't feel as tired. They don't have as many side effects as they do with metoprolol. These two drugs, carvedilol and nebivolol, are especially good for lowering the blood pressure in these patients. So you have those good options. If a patient has severe, as opposed to mild COPD in this case, if a patient has severe COPD, then, only then, would you try verapamil and diltiazem as the non-dihydropyridine calcium channel blockers. I hardly ever use digoxin anymore because it's been associated with increased mortality, especially high plasma levels of 1.2 nanograms per milliliter. And especially in women, I don't like to use digoxin because there is an association with increasing breast cancer as well. And if absolutely necessary, we can use amiodarone for rate control. I hardly ever use that because they might convert. And if you haven't anticoagulated the patient, it might not be a good idea. But if the patient really needs more rate control and they cannot tolerate the others, then amiodarone is an option. So like I said, the patient has mild COPD, so you can use the beta blockers. You should not hold beta blockers in somebody with mild COPD, especially the beta 1 specific beta blockers are fine. Now, he has a past history of COVID-19. What does that do for his case? We know that new onset atrial fibrillation has been seen, but it's low. It's 3.6 to 6.7% in patients without cardiovascular disease. However, in patients with cardiovascular disease, it's very high. You can see as much as 36% of patients with cardiovascular disease have atrial fibrillation during their COVID bout. And in the last COVID task force health from Italy, they showed that up to 25%, so a quarter of patients who did not survive COVID had atrial fibrillation. So it's a marker of increased mortality in patients with cardiovascular disease. So I hope I've convinced everybody that this patient should only be treated with rate control. Thank you so much.
Thank you for inviting me, Dr. Sharma, Dr. Parwani. And thank you, Dr. Waldman, for that great presentation, but I remain unconvinced. So my side of the debate is catheter ablation is the preferred strategy. My name is Rahul Bardwaj. I'm an electrophysiologist at Loma Linda University, which is in San Bernardino, California, or close to there. So the case scenario that I was presented, this is a 54-year-old man. He has had recurrent paroxysmal atrial fibrillation with the prior hospitalization. He had congestive heart failure diagnosed with preserved ejection fraction, New York Heart Association Class 2. His medical history is also notable for COPD and prior COVID-19 infection. So the questions that were raised, should catheter ablation be recommended? Is rhythm control with catheter ablation as effective and safe as rate control? So to delve into that a little more, I asked myself a few questions. Is rhythm control better than rate control? And the answer is yes, rhythm control is better than rate control. How effective is catheter ablation compared to medical therapy? Catheter ablation is more effective than antiarrhythmic medications. How safe is catheter ablation? Catheter ablation is getting safer. It's safe and it's getting better. And what is the optimal timing for pursuing catheter ablation? Early catheter ablation is better. And I have some evidence to back this up. So a lot of the guidelines that were presented were based on seminal trials such as AFFIRM and RACE. So in 2000, MERIT-HF was published, and 2 years later in 2002, AFFIRM and RACE were published. This is the same year Copernicus was published. To put that in perspective, that was shortly after Y2K. BOUT was just released, and it was 2 years before Facebook. And what has happened since then? A lot. So we've learned about Plavix. We've learned about the COURAGE trial for symptomatic control of CAD. We've had trials published on dabigatran, Eliquis or apixaban, and rivaroxaban. Force sensing catheters were approved. Watchman was approved. And in 2020, East AFNet 4 was published in 2020. And in the same time frame, a lot has happened in the world. A lot of Bollywood movies with Shah Rukh Khan have come out. And over the years, Shah Rukh has changed, and so has cardiology. And I'll confess, out of all of these movies, the only one I have seen is Devdas. So I'm living in the past, but I would urge that you wouldn't live in the past when it comes to the strategy of how you treat atrial fibrillation, because a lot has changed. And one of the things that has come up is that we've learned about problems with AFFIRM and that prior strategy. In AFFIRM, 4,000 patients were randomized to rhythm control versus rate control. They were followed for about 3.5 years. And the outcome was pretty similar in terms of mortality. But we do know that in that study, 2/3 of patients were on amiodarone or sotalol. Digoxin was used in a large percentage of patients. And a lot of patients weren't on anticoagulation. Only 70% of patients remained on anticoagulation in that study. And there was a lot of crossover. 38% of patients in the rhythm control arm crossed over to rate control. So we learned those lessons and we took them to East AFNet 4. East AFNet 4 was a study sponsored by the German Ministry of Health, and it was done across Europe, multi-center, with about 2,800 patients that were followed for about 5 years. The study was actually stopped prematurely because it reached the efficacy endpoint at the third interim analysis. And what they found was that there was a statistically significant reduction in the risk of death, stroke, or hospitalizations for heart failure or ACS in the rhythm control arm. And this is important because this trial is more relevant to modern practice as compared to the older trials that the guidelines are based on. The older trials, which include AFFIRM and Orbita, largely look at patients over 65, over 10 years older than our patient. And if you look at the efficacy outcomes, when they go to the different components, death, stroke, and hospitalization or death and stroke are both statistically significant. And how was rhythm control achieved? In this study, 40% of patients were on 1C antiarrhythmics, 20% were on amiodarone, and about 16.7% were on dronedarone. So this is far less amiodarone use than the older studies. And we know amiodarone doesn't do anyone any good if it's used in the long term. 8% were initially treated with catheter ablation, and after 2 years, that changed to 20%. And I guess I should add that a lot of symptomatic patients were excluded from this analysis, since we know that rhythm control is better for symptoms than rate control. And a large meta-analysis of PAF trials has been published. This is a recent one from 2021. And this demonstrated in this large number of trials since 2001 that there was mortality benefit with AF ablation. There's a decrease in hospitalizations with AF ablation, and there's an improvement in heart function. Another study looking at the same, but more recently and looking specifically for arrhythmia recurrence showed similar effects. That risk of arrhythmia recurrence was better with ablation. Risk of adverse events tended towards favoring ablation. Symptoms recurrence did better with ablation, and risk of healthcare utilization favored ablation. So what that tells me is that East AFNet 4 not only showed that rhythm control is better than rate control, they didn't even use the most effective and safe rhythm control modality in the majority of patients. So other benefits, quality of life. Dr. Voldman mentioned quality of life, and I think that's one of the most important things we do for AFib. And I struggled with finding just one trial to show you. So I have a bunch. So first, this is the Cabana Trial. The Cabana Trial was an important rhythm control versus rate control rhythm control with ablation versus antiarrhythmic therapy trial. It was international, multi-center. And what they found was across the board, using multiple scoring systems, ablation was better than antiarrhythmic therapy. Another study looking at force sensing catheter ablation showed similar effects. With catheter ablation compared to antiarrhythmic therapy, there was an improvement in the AFEQT composite score, which is a measure of quality of life. And this was similarly demonstrated by the Cleveland Clinic Group in their self-reported outcomes after catheter ablation. 80% of patients were super responders and had an improvement in quality. And the VisiTac study, which is looking at post-analysis of AF ablation, showed similar improvement. And again, the Cabana Trial. And these are just a small number of the studies. All of these studies basically show in the general AF population, catheter ablation improved outcomes as compared to medical therapy, and also improved healthcare utilization in patients. So it's very clear that ablation improves quality of life compared to doing nothing or rate control, and as compared to antiarrhythmic therapy. This is a meta-analysis showing that. So beyond quality of life, there's other data that I want to present to you, and I'll be quick about this because this is still ongoing work. Dementia is something that's important in AFib. We know there's a significantly increased risk of dementia and atrial fibrillation. This is a large cohort of patients. And this happens for a number of reasons: cerebral infarcts, decrease of brain volume, cerebral microbleeds, and a lot of that is related to comorbidities, but also because of AFib. And this is a study from the Swiss AF group, and I'll just brief that. Basically, a large number of infarcts are found on random MRI in patients with atrial fibrillation, large of them silent. So 20% of patients had large non-cortical or cortical infarcts, 15% were silent. And in a follow-up study in 2 years after initial baseline MRI, 5.5% of patients had new infarcts. That's 88% of patients who were on oral anticoagulants at the time. So we know that patients have worse neurological outcomes with AF. And there's preliminary data that's showing that rhythm control may improve outcomes. And this is one small study looking at 308 patients, one underwent catheter ablation compared to 50 controls. And what they found is that the ablation arm had improvement in the cognitive outcomes. So this is interesting, but very preliminary data. Beyond that, there's improvement in outcomes in quality of life and hospitalizations and mortality in heart failure patients. And we know that heart failure and AF are often linked, and there's a high coincidence of the two conditions. And there are a number of trials, but I'll focus on ATTACK, which showed a significant improvement in mortality and unplanned hospitalization, and CASTLE-AF, which showed the same. And this is in 400 patients, looking at a composite of death or heart failure hospitalization. So I won't spend too much time, but I will mention that both the co-endpoints were statistically significant, hospitalization and death. And that is important to note that quality of life improved even when AFib wasn't eliminated. So I think in the interest of time, I'll just skip ahead. AF ablation is safe, getting safer. We've improved with vascular access, catheter design, ablation technologies. And overall risk of acute complications is low and getting lower. So timing-wise, early ablation is better. I think I'm running short on time, so I'll just skip to the conclusion. Catheter ablation should be pursued early in the disease course for this patient with symptomatic paroxysmal AFib and congestive heart failure. Catheter ablation is more likely to improve his quality of life, quantity of life, and potentially reduce risk of other adverse cardiovascular events or dementia. Thank you.
Thank you, Dr. Rahul and Dr. Annabelle. So, now I would like to invite my co-chair, Chirayu and Hiren, and the moderator, Dr. Shukla, Dr. Saxena, and Dr. Brahmbhatt to discuss on the topic, which was very good. So, and I think we will have 8 minutes of discussion right now. So over to you, Chirayu and Hiren.
That's a very good topic to discuss, surely. But here is where I'll just like to put a point straightforward that rhythm control, especially in this patient, would be definitely much better, especially if taken early on. But the problem that we would face, if at all this patient is here in our setup, especially India and Gujarat and our locations, that is where the problems would just start creeping in terms of the patients getting very, very difficult to just understand the fact that this is a form of therapy which is going to get it permanently cured, because it has to be dealt with obviously in 3-dimensional mapping system, which is where the cost factor comes around and the insurance problems turn around. That's a major concern. We just lets these kind of procedures just stay away, and this is how the main problem starts, and that is how we just have to go unfortunately towards rate control.
Can I just say, I understand the difficulty all over the world where there's not a lot of access to catheter ablation, but I think that the one thing that we can do for our patients is to identify what is causing their atrial fibrillation. Just like, the C and the ABC, we have to identify and manage the risk factors. If he's drinking too much alcohol, that's an easy thing that we can encourage him to stop doing. If he's obese, or if he has pulmonary hypertension, as the echo shows, he may have sleep apnea, he may have obesity, he needs to lose weight and do those lifestyle changes. The one thing we did not talk about, Rahul, is the shared decision making, which is in all guidelines now. That shared decision making is the best way to decide what is the best thing for the patient. So I agree with Rahul that early ablation is good, as long as you have the ways to do it and it's safe and the patient agrees to it, knowing that, Rahul, you have to admit that there is a recurrence of atrial fibrillation, especially after 4 years. You're going to have to probably do it again, hopefully with better tools, right?
Oh, yeah, that is a good point. And atrial fibrillation ablation is not really curative, I would say. As one of the leaders in our field, Dr. Natali would say, it gives us the best shot of AFib remission. And that does count for a lot. Simply reducing the burden of atrial fibrillation has been associated with improvement in outcomes. That was shown in Castle AF in terms of hard outcomes like death and hospitalization. And it has been shown in other studies in terms of improvement in quality of life, including that slide I flashed through from the Cleveland Clinic self-reported surveys. So even though we don't have a cure, I would say, with ablation, we do improve outcomes. Now, with regards to the question about tools, electroanatomic mapping is certainly not easy and widely available in certain parts of the world, but tools are improving and becoming cheaper. I understand cryoablation has now become more prevalent in India. And what we're all looking forward in EP is pulse field ablation, which also may not require 3D mapping. That probably wouldn't be cheap initially. But certainly these new technologies and techniques will improve outcomes, they'll improve safety, and I think give the best benefit to patients.
Rahul, couple of questions from my side. This patient has got a normal LV function with a mild COPD. So what is the threshold of suggesting upfront RF ablation rather than putting them on 1A or 1C medication along with the beta blocker to see how good the response of antiarrhythmic medication?
So that's a great question. The guidelines up until recently, I think actually the most current guidelines would say both are reasonable first-line approaches, but the paradigm in the field has shifted towards catheter ablation first because we know that outcomes are better the sooner you treat. And antiarrhythmic drugs are kind of kicking the can down the road. They're not as effective. And eventually, a catheter ablation does become necessary. We know that AFib begets AFib. So the longer you sit in AFib, the worse off the patient will be because you get progression of atrial myopathies. Atrial myopathy occurs for a variety of reasons. There's growth scar with calcium channel changes in the atrial myocytes. But there are a number of reasons why AFib ablation becomes harder after you wait. Atrial gets larger. Basically, we know based on these studies that there's a finite window of opportunity that we have for getting the best possible outcome. So that's why I think the shift has become towards early intervention. Earlier ablation has better outcomes.
That's great. And the other thing is, what is the success rate? If you're doing an ablation, what is the success rate and how do you counsel the family? Probably require a second procedure after the first procedure.
So it depends on the scenario. So in terms of paroxysmal AFib, there's a variety of studies that give ranges between 70 and 95% success rate. And that's a 1-year outcome. 1-year follow-up. I generally quote around 80% with paroxysmal AFib. With persistent, I quote around 60, 65. And I tell them, look, this isn't curative, but when you look at 1C antiarrhythmics, the 1-year outcome is 40% success in keeping people in rhythm. If you look at Amiodarone, that's 70% success, and that comes at a cost of higher toxicities. So I generally wouldn't do a 1C antiarrhythmic in most patients unless I had no choice. So when I talk to patients, I tell them that there's a 80% chance this could work. We don't really have good long-term outcome data. So there are old studies that look at 10-year outcomes, and that was done a while ago. There's registry data from Europe looking at, I think, a Danish cohort of patients undergoing catheter ablation back in 2003, but it's not really relevant in today's population because our techniques have changed so much with the advent of cryoablation, which I don't do, but catheter, force sensing catheters, understanding how to do wide antral circumferential ablation. All these techniques have changed how successful we are. So I don't really have the data to provide patients, unfortunately. But
still, they say if you're going for cryo, you still need to put some RF ablation so that the recurrence is a little less.
Yeah, I don't do cryo, so
okay.
I do RF.
Okay, maybe one or more two questions from the moderator. If any of the moderator wants to ask any questions, so then we will wind up the session. I don't think Hiren is here, right? Hiren is.
Any comments on pill in pocket? I was wondering if that would work, because a lot of patients in India do tend to do that. They'll take a pill in pocket in the sense of flecainamide, which is easily available in India, and they would rather not get ablated. Comments from both of you?
Yeah, let me speak first, and then I'll let Rahul talk. I use pill in the pocket all the time for my young patients who have a cardio monitor and iWatch. Who can be told that they have atrial fibrillation, because sometimes they have palpitations and it's just sinus tachycardia, but if it's AFib, they're trained to take their pills, and it works really well. So I think it is a great tool for certain people. I think that as catheter ablations improve, and it's available, I think it's an option that we should consider. I mean, I'm very happy with the recent trials that have shown that atrial fibrillation can be treated with either antiarrhythmic drugs or catheter ablations, because there's really no significant difference between the two, but I think catheter ablation will win in the end.
Great. So, Kamal, I think we will wind up the session because it's all.
I think there was a question that Dr. Parvani, which was very relevant, about the inflammation that he had from the COVID.
Yeah, please go ahead, answer that, please.
I think that, we do need to wait. This is very similar to the stress that patients experience after surgery, especially any cardiothoracic surgery. There is a lot of inflammation. But we do know that in patients who do go into atrial fibrillation will probably have atrial fibrillation again. They probably have the substrate that makes them go into AFib. So I would wait to let the inflammation go down, and if they have any recurrences, then I would consider more treatment, such as antiarrhythmic drugs or therapy or catheter ablation. Rahul?
Yeah, I agree. I think that if it was just COVID and one-time AFib, I would probably not take action, but the odds are that it will recur. And in fact, in this case presentation, it did recur. It was recurrent paroxysmal AFib. I think the COVID thing was an acute issue that may have been the initial index event that led to the diagnosis, but he may have had it before. And that leads me to something about that previous question about pill in a pocket. I also use pill in a pocket for many patients who have symptomatic AFib, but I think it's important to remember that most patients with paroxysmal AFib don't feel every episode. In fact, they probably don't feel the majority of episodes. So what that implies to me is that while a pill in a pocket can certainly improve quality of life and restore sinus rhythm for patients who have symptomatic events, it may not do a whole lot to prevent progression of disease, because they may be having a lot more AFib than we realize. And again, kicking the can down the road, the AFib may be harder to treat in the future.
I think if you have COVID, people do use Novax left and right, and I think that would tilt the table more in favor of Dr. Annabelle than Dr. Rahul.
Thank you.
Dr. Anup, I think, Chair, we can end the session now.
Yes. Wonderful. Thank you very much, both Dr. Annabelle and Dr. Rahul, and wonderful talk. Thank you very much.
Thank you so much for inviting us.
Thank you, everyone. Thank you, Chairperson. Thank you, moderators. Thank you, both the speakers, Dr. Annabelle and Dr. Rahul. Thank you for being with CardioCon this year.